So next is pilonidal sinus. A 25-year-old man comes in via A&E with pilonidal swelling on his left buttock, which he has for 3 days. On examination, you see an abscess just to the left of the middle cleft, which is what is it and how would you treat? This looks like acute pilonidal abscess, so he needs CNN drainage and leave the wound open to heal by secondary intention. So you have to be very vocal. In the theater, you see several midline pits and evidence of recurrent abscess. So what you remove as well? Would you remove this as well? No, there's a high risk of recurrence if skin surgery is performed at the same time. Incision drainage will lead to definitive cure in up to 50% of the patients, so 50% will come back for elective repair. How do pilonidal sinus develop? So ingrowing hairs, negative suction in the natal cleft become the focus of infection. There also has been finger web spaces of hairdressers. They can discharge often in the midline, leaving a sinus tract and pelvic visible pit. What are the risk factors for developing pilonidal sinus? So male gender, hirsute individuals, sitting occupations from lorry drivers, deep natal cleft and hair in the natal cleft, and family history, obesity risk factor for recurrence. What bacteria are typically found? So it's mixed aerobic and anaerobic are found. Staph aureus is the most common in the skin commensal. The patient comes back to you in the clinic a couple of months after another sepsis that went exponentially. He wants surgery to stop it from the happening. How will you advise him? First of all, he needs a lot of education. So in keeping with the Montgomery ruling, I would inform him of all the treatment options, including option to opt for no treatment at all. I would advise him that this is a quality of life operation and it should be performed at a convenient time that is socially convenient for him. So number one, conservative treatment. I would advise him to lose weight, consider regular hair removal by waxing, hair laser or shaving. Keep the area clean, avoid sitting for a long duration of time. Then surgical, patient must bear risks and risks of the surgery like recurrence, delayed wound healing, non-wound healing, wound breakdown. He should be told about the potential need for negative therapy dressing and potential in terms of the potential inconvenience as well as possible financial implications. Surgical options: scrape out the track and close with fibrin glue. Bascom's procedure, Caridacus flap and Limburg rhomboid flap. So describe the operation you are most familiar with. So I am keen of Limburg flap. So patient is in the prone position. Measure the pits and sinuses in your area which you're going to exercise, and so it should be, I will draw the midline measurement, then 60% of that on both sides, join this, and then I will draw a parallel rhomboid here to exercise the first diseased area. Then I will create the flap which will be surviving on the perforators, and then I will fix it with the Prolene 2 and matrix sutures. We can do Caridacus flap, is the easiest to understand. So prone position, exercise the ellipse of the skin and fat lateral to the midline containing all pits and tracts, and medial skin flap undermine and mobilize laterally to close the wound off midline closure. So flatten the natal cleft. Factors negating the primary closure: presence of the pus, steroids, biological agent, diabetes and smoking. Need for negative pressure dressing. Thank you.